Have you ever imagined how bleeding stops from an injured vessel or worried regarding the concept of hemostasis for your NEET PG examination? Let's explain the hemostasis in an easier way. First comes the primary hemostasis. It's like putting a bandage on the injured vessel. It starts with vasoconstriction, then adherence of platelet to the exposed collagen of the blood vessel via GP1B9 and von Willebrand factor. These lead to platelet activation and shape changes, which result in granule release reaction. ADP, thromboxane A2, serotonin released, and more platelet are included with exposed GP2B and 3A on the surface. Von Willebrand factor is bound to GP2B3A and platelet aggregation occurs to form a plaque. Primary hemostasis is fast, but the plaque is weak. Now comes the secondary hemostasis, making the plaque stronger and stable. Coagulation factors activate in cascade and starts with factor 7 interaction with tissue factor via extrinsic pathway. In the intrinsic pathway starts with factor 12, then factor 11, then factor 9 activates. Activated factor 7 and factor 9 activates the factor 10. Factor 8 helps the factor 9 to activate the factor 10. Activated factor 10 activates thrombin to form fibrin. The fibrin stabilize with factor 13 to form the fibrin mesh clot. So in this complex pathway of hemostasis, multiple defects can be observed, ultimately leads to bleeding with different clinical manifestation. Disorders of primary hemostasis is noted with defects of vascular injury, von Willebrand disease, thrombocytopenia, platelet function defect, or other acquired platelet function defects. This disorder leads to easy bruising, petechiae, epistaxis, gum bleeding, excessive bleeding from minor cut injury, or menorrhagia. GI bleeding may be seen in severe phenotype. All the bleedings are superficial type. Two most important platelet function defect you should know. These are Bernard-Schulze syndrome and Glanzmann thrombosthenia. In platelet function test, Bernard-Schulze syndrome shows no agglutination with ristocetin. In Glanzmann thrombosthenia, agglutination only noted with ristocetin but not other agonist. Secondary hemostatic defect leads to deep bleeding like ecchymosis or joint bleeding. The screening investigation for secondary hemostasis are prothrombin time, activated partial prothrombin time, or thrombin time. The PT evaluates the extrinsic and common pathway. PT increases in liver disease due to deficiency of factor 7 and warfarin uses. APDT evaluates the intrinsic and common pathway. APDT increases in hemophilia due to factor 8 and factor 9 deficiency. Global assay is an in vitro test designed to mimic the physiological process of blood coagulation, providing comprehensive view of entire clotting process until the clot is resolved. Two platforms are available for global assay, TAKE and ROTEM. You should know the interpretation of TAKE tracing. The R time is the enzymatic phase, the reaction time correlates with APDT. Then alpha angle denotes the rapidity of the clot formation. MA is the maximum amplitude of clot formation. The strength of clot after 30 minutes of MA is noted as A30. This evaluates the clot lysis phase. At the end, we have to remember some points which are important for your exam. Primary hemostasis forms the platelet plaque via adhesion, activation and aggregation. Secondary hemostasis strengthens the plaque with fibrin via coagulation cascade. PT tests the extrinsic and common pathway prolonged in warfarin therapy and factor 7 deficiency. APDT checks the intrinsic and common pathway prolonged in heparin use and hemophilia. Global hemostatics test evaluate the complete procedure of clot formation to resolution used in monitoring cardiac surgery. Thank you. Please like, share and subscribe the channel for future content.